Okay, so thank you all for joining us. Again, we're going to hear today from Robert Spiegel, who's the Chief Medical Officer of PTC Therapeutics. He will provide an update on Ataluren in Duchenne, and we'll talk about the new clinical trial. Just a little bit of ground rules. Dr. Spiegel is going to speak first, and he will be presenting a series of slides. If you want to ask a question, you can type your question into the chat box. We're going to try and get to the majority of questions at the end of the talk. So go ahead and put your question in. We can scroll back and see them, and we'll ask those questions at the end of the talk. We're recording the webinar, and we think it's very likely that we will be able to make it available with some period of time after the presentation. So we will find out for sure and get back to you, but we think we're going to be able to make that available. So with no further ado, I will turn it over to Bob Spiegel.
Thank you. So good afternoon to everyone on the phone, and thank you for joining us. And I want to thank PTMD for setting this up. We're really looking forward to this chance to bring people up to date on our development of Ataluren. And what we'll be doing is briefly reviewing some prior data that some of you may have seen, but importantly talking about some new analyses of that data and talking about our new phase 3 study in nonsense mutation DMD, and then giving you an update on some of our recent regulatory interactions too. And then we're going to save time at the end for your questions. So just to begin, whoops, doesn't advance. Let me see what I do.
The right arrow.
Let me see if I can do this here. Sorry. There we go. So PTC is now a public company since last summer, and in that regard, you should be aware that everything I present today will be information that's been publicly disclosed before, but we always now present a forward-looking statement, which is to comply with the SEC, the Securities and Exchange Commission, just to say that some of the things we say are projections of things that will happen in the future, and everyone should know that the words we use are carefully chosen to be clear about what is known and what's a prediction or a possibility of things, particularly regarding PTC and Ataluren.
Bob, could you speak a little bit closer to the phone?
Okay.
Thank you.
Okay, let me know if that's better.
Yeah, that's so much better, thanks.
Good. Okay. So again, the agenda for today will be a summary of some of the phase 2 and phase 2B studies with Ataluren in nonsense mutation Duchenne muscular dystrophy, and then importantly, a description of our new confirmatory trial, a new phase 3 trial that we call ACT-DMD, or Ataluren Confirmatory Trial in Duchenne muscular dystrophy. I should say ACT-DMD, not NMD. We'll talk briefly about the trial design and how it compares to the previous study we did, talk about the inclusion and exclusion criteria, and certainly urge you, if you believe your child might be eligible for this patient, to get in touch with our study centers, and we'll give you some information at the end about getting more information about this trial as well. And then, as I said, we wanted to provide you with a regulatory update and then reinforce how more information can be obtained by you. So let's go into some of the previous information from clinical trials with Ataluren. We did what's called a phase 2A study. This was one of our first studies in DMD boys who had a nonsense mutation, where we were mostly interested in the tolerability of Ataluren at different doses, and we obtained muscle biopsies to try and detect the presence of dystrophin after being exposed to Ataluren for a brief period. And this has now been published. Dr. Finkel was the first author on this publication. And this one slide and one picture shows that 61% of the patients who were exposed to Ataluren in this trial at different doses did show an increase in the dystrophin staining that can be detected in these muscle biopsies after 28 days of Ataluren treatment. And this was very encouraging and actually formed the scientific basis of what we call a proof of concept, to give us confidence that we had a rationale to go into a larger phase 2B study where a larger number of patients with Duchenne caused by a nonsense mutation would be exposed to Ataluren or to a placebo. Many of you are familiar with this trial and might have even seen this slide before showing the design of what we called our study 007. It was a phase 2B study that studied Ataluren at 2 different doses versus placebo. There was a randomization at the beginning and a stratification of boys based on how far they could walk in the 6-minute walk test and whether they were on steroids. And the boys were, after randomization, approximately 60 patients in each group, were followed for a year, either receiving the placebo treatment or Ataluren at a dose of 10-10-20 that we now sometimes refer to as a 40-milligram dose. The dose was broken into 3 oral administrations a day, or they received 20-20-40, which we sometimes call an 80-milligram dose, similarly over 3 times a day. And the primary endpoint of this study was the 6-minute walk distance. And many of you know that we had worked with the investigators in this trial to assure ourselves and them that the 6-minute walk was a reasonable and reproducible endpoint. And we learned a lot from this first very large randomized controlled trial about administering that test and the type of variability you might expect to see in DMD boys of this age greater than 5 years old when they're followed for a year. And even though many of the registries that had been established were very useful, we really consider this a very important large database now to go back and look at to understand what would be the natural history of boys, particularly those on the placebo arm of the study. And it helped inform us when we finally saw these results about variability and also about collecting 6-minute walk as a primary outcome and also some of the other secondary endpoints that we were studying in this study. First, let's just briefly review the safety. And as many of you know, we're very pleased that Ataluren, across all of its studies, which now include exposure in over 600 patients, has been quite well tolerated. The side effects that we tend to see are most commonly GI-related, such as vomiting or diarrhea in a small number of patients, headaches, and then the kinds of things that you see whenever you do a study of patients or relatively healthy boys over a year, such as fever, cough, abdominal pain. But as you can see, the incidence of side effects was quite similar between placebo and the 2 doses of Ataluren, and even at the higher dose, we didn't see an increase in grade 1 to grade 4 side effects. So overall, and importantly, when we have our discussions with regulatory authorities, the benefit to risk of Ataluren seems quite favorable because the safety is quite good and it's well tolerated. And in this large study that I'm about to give you the efficacy results from, we had extremely good compliance and very few patients who ever dropped out or had to discontinue because of side effects. Moving to the key efficacy outcome of this phase 2B study, we first look at what's called an intent-to-treat analysis, which means you take all the patients and you look at how they did versus what the protocol said was going to be the primary endpoint, which was the 6-minute walk distance after a year of treatment. And this primary outcome shows that among the boys treated with the lower dose of Ataluren versus the placebo-treated boys, there was approximately a 31-meter difference in how much their 6-minute walk ability had declined over a 48-week period. So as you can see, the boys on placebo declined an average of about 44 meters over a year in how far they could walk versus 12.9 or 13 meters in the boys who were treated with the low dose of Ataluren for a 31-meter difference. And we had hypothesized before the study began that if we could show about a 30-meter difference, that would be meaningful, both because other drugs that have been tested in other diseases have gotten FDA approval and have tended to be felt to be clinically meaningful when they have about a 30-meter difference in the 6-minute walk test. And we also thought that it could predict for other changes in these boys' future activities, and that's been validated by some very recent publications suggesting that the 6-minute walk, while it has some limitations and some issues with it, it is a very good predictor of when other milestones of the disease might begin to also show deterioration. And if you could save this much 30 meters in their walking ability, you'd have a good chance that if you keep following these boys, you might also be able to delay other milestones of the disease. We also, as a prospectively identified endpoint, wanted to look at how many boys progressed by a new definition of progression, which was how many boys, taking the same data of their 6-minute walk, how many showed a 10% decrement in their walking distance. So this is just a different way of looking at the same data with what's called a progressor analysis. This is used in other clinical trials in other diseases. And using this definition, 44% of the boys who were on placebo showed this level of progression of 10% or greater in their 6-minute walk versus 26% of the boys who had been treated with the low dose, the 10-10-20 dose of Ataluren during the same 48-week period. So again, we thought this was a confirmatory analysis that spoke to the robustness of the data, that this is a different way to look, and we thought being able to say 26% of boys progressed versus 44% on placebo was another way to indicate that we had done something meaningful for the boys in this study. As I mentioned, one of the things we've done in the last year or two is go back to this data and see what other learnings we have in it that could be used both for ourselves and for the whole community that's interested in treating this disease and coming up with new treatments for boys both with nonsense mutation and any other cause of Duchenne. And this is a somewhat busy slide, but let me see if I can, I have a pointer here. Harder for me to find my pointer, if it's there. No. Well, I'm using a pointer. I hope you can see. On the left-hand side, there's a small circle. And this shows, on this graph, we're looking at boys by their age on the x-axis and what their baseline 6-minute walk was on the y-axis. And in the circle that's called Maturational Improvements, we're showing on this slide, each arrow represents one boy in the placebo arm of the trial, and the arrow begins where they began with their 6-minute walk distance, and the tip of the arrow shows where they were at the end of a year. So in the left-hand side, we see that boys who were less than 7 years old and who began with a 6-minute walk, let's say greater than 300 meters, tended to be relatively stable, some even improved while their muscles are growing during this age. So boys in this circle are what we're calling a maturational improvement phase, and if you put them into a study, you might not expect to see much change because even on a placebo, their 6-minute walk distance is not going to fall very much during 1 year. The red circle next to that we call stabilization, and we're saying even older boys, if they begin with a 6-minute walk distance of greater than 350 meters, some of them decrease. You can see some arrows that are going downward, but many of them, again, stay stable or even increase. So again, if you start with a 6-minute walk distance greater than 350, you would be choosing a population that might not be able to show the effect of a new drug because even on placebo, they might not be decreasing. But in the green circle at the bottom, you see a group that we call boys in their decline phase of ambulation. And these boys, both by being greater than 7 years old and starting with a baseline 6-minute walk distance of less than 350, are more likely to be in a decline phase. And if you were testing a new treatment that you thought had a treatment effect, this might be the ideal group to study because during a 1-year period, you'd be able to compare a group that was declining on placebo to a group that hopefully is being stabilized with, particularly with a drug that has dystrophin restoration as its mechanism of action. So we think this is an important learning, and this has been published in some scientific publications and presented at many of the DMD meetings in recent years, and it's also led to both ourselves and other developers of new drugs trying to think a little bit harder about what types of patients you would want to include through inclusion and exclusion criteria in new studies. And we'll talk a little bit more about this now when we talk about our own new study. Let me advance the slide here. What happened to my advance? There we go. Okay. Whoops. I'm going to go back a slide here. So what this slide shows is we went back to our data and we said, what would our data look like if we looked at the result of the Ataluren treatment only in those boys who were in that decline phase that I showed in the previous slide with circles on it? And this shows that if you look at these boys only about 32 patients on the low-dose arm and 31 in the placebo arm. The placebo arm declined by 62 meters in this group of boys, whereas it only declined 12.3 in the group treated with Ataluren, resulting in a delta or a difference of about 50 meters. So whereas in the overall group, we had about a 31-meter average difference between those treated on placebo and those treated on Ataluren, in this decline phase of the disease, we have about a 50-meter difference. And we think this is important, and we think it speaks to what Ataluren might really be doing. But we do have to add the caveat that this is called a post-hoc analysis. It wasn't pre-specified in the protocol, and it's something that we did after we had seen the data and done the primary analyses. We also have looked at the other group of patients. So while it's easiest to see the effect of Ataluren in the boys in the decline phase, we, in fact, when we look at any stage of the disease from the boys who were in the 007 trial, we still see a benefit of Ataluren. It's just not as marked. So this is one other way to cut the data. We're looking at boys here in 3 different groups based on what percent predicted they were able to walk at baseline. So when we use this analysis, we take boys when they enter the trial, and we do a calculation based on their age and their height of how much they should be able to walk versus some large databases of how average boys are expected to perform on a 6-minute walk distance. And we take the boys at entry into the Duchenne trial, and we say what percent of what you would expect were they at entrance. Now, they could be 100% if they were just like an average boy, or they could be on the left-hand group of bars greater than 70% of predicted. And here the gray box with 20 patients only declined an average of 8 meters if they were on placebo, and the boys on Ataluren actually improved 12 meters if they were in this greater than 70% predicted at baseline. In boys in sort of a middle group who were somewhere between 50% of predicted and 70% of predicted, the placebo group went down 38 meters, but the Ataluren-treated group again went up 9 meters. And as you can see in the group that's less than 50%, which includes but is a little bit different than the analysis I just showed you of the decline phase patients, the placebo group in boys who were less than 50% at baseline went down 116 meters in their 6-minute walk, whereas the boys on Ataluren only went down 75 meters. So the conclusion we reach from this is that Ataluren treatment effect is seen in all stages of the disease that we studied, but it is most marked in the boys who were in the decline phase or entered the study at less than 50% of their predicted walking ability. This is just one more analysis that's similar to this. We also looked at what we called the secondary endpoints in our study. The 6-minute walk distance was the primary efficacy measure, but we also measured the standard time function tests, such as the ability to climb stairs, the ability to descend stairs, and the ability to run or walk 10 meters. And this is a busy slide, but it basically, again, is showing that on the left-hand side in stair climb on the left, the first 2 bars show all patients, and this is a little bit difficult to orient you to, but the arrow on the left shows what an improvement would be. The boys on placebo, among all boys, took almost 5 seconds longer at the end of a year to climb stairs, but the boys on Ataluren at the low dose only took 2.4 seconds longer at the end of a year than they had at the baseline. If we look at the boys who were in the decline phase, the boys on placebo declined a little bit worse, almost 5 full seconds, and the boys on Ataluren who were in this decline phase declined a little bit less than the group altogether. So if we look across these 3 different measures of time function tests, it's just another way of saying that this particular group that we call boys in the ambulatory decline phase of the disease, again show even more benefit from an intervention like Ataluren, and this might be an ideal group to study in the future, both for the 6-minute walk and for the time function test. So all of this has informed us and taught us a great deal about how to do a new study, and we are doing the Dmd study, the Ataluren Confirmatory Trial in DMD, to once again go back and treat boys in a randomized control, placebo-controlled trial with Ataluren, and I'm going to show you the design of this study. And I'm going to say right now, and I'm going to repeat at the end how important this study for us, because for both the FDA and for the European regulatory authorities, it's extremely important that we do this confirmatory study and confirm the results that I just reviewed with you from the Phase 2A or 007 study, and it will be pivotal from what we know from our interactions with the regulatory authorities to complete this study and bring these results to them to confirm all of the positive effects that were suggested in the first study, but to show that we can do it in this study as well. So this study, this is a schema that hopefully you should be familiar with from what I showed before. This time there are only 2 arms that boys will be randomized to. They'll either get placebo for a year or they will get the 10-10-20 dose of Ataluren. And at the end of a year, all the boys will be eligible to move on to an open-label extension, which is something we did in the first trial. And we think this is important both for us to obtain long-term data on both safety and efficacy of Ataluren, but also to give, frankly, to give parents, the patients, and their physicians an incentive to enter into the trial because everyone will be able to get the Ataluren afterwards. I'm going to go into detail in the next 2 slides on the entry criteria, but basically in this study, the boys need to be greater than 7 years old and less than 16, and you could see from the analyses I just walked through why we think that's important. We want all the boys to be on steroids in this study. If they're not on steroids, they can go into a lead-in period where they get placed on steroids and get a stable dose of steroids. And we think that will decrease some of the variability that we saw in the first study, and it eliminates one more variable if all the boys are on steroids. And then we have some criteria that say, again, based on the analyses I just showed you, we want the boys to be greater than 150 meters at their baseline 6-minute walk distance, but we will also have a cap at the top that says boys are approximately 80% are predicted so that we will be best suited to try and show a deterioration in the boys and show the effect of Ataluren in this new study. The primary outcome will again be the 6-minute walk distance. And in this slide, we're comparing the endpoints that we did in the first study versus the new Dmd study. The primary endpoint remains the same, the 6-minute walk distance, but we've simplified and reduced the number of secondary endpoints. And we've also added something new. The North Star assessment is now being increasingly used as a composite of different tests that the boys can do. It's not, we don't think it will be particularly intrusive or hard for the boys to do it, but it's becoming more widely used as another way to gather these secondary endpoints into one measurement tool. And we also have an activities of daily living survey, which is something we've started to use in the extension study of our previous studies. And again, we've heard many reports from parents and anecdotes about other things that they noted while the boys were on the study that weren't as well captured in our standard case report form. So we've created a questionnaire and a survey that we hope is going to be able to give us some insights into other things that are happening in the boys' lives that we might not capture through these standard tests. Of course, standard safety assessment will also be collected, and it will add to our overall information about boys who have been exposed to Ataluren for long periods and what to expect. As I said, this slide details the major inclusion criteria. Obviously, the boys are males, ages 7 to 16. They should have clinical symptoms or be diagnosed by age 6 with an elevated serum CK and some evidence of difficulty with walking when they're entered into the study. We will need genetic documentation of a nonsense mutation as the cause of their DMD. As I said, the boys will be asked to be on a variety of standard regimens of steroid use. And there will be a screening 6-minute walk test that's important because we need to see that the boys can walk at least 150 meters, and there will also be, as I mentioned, a cap on how much they walk to show that they're somewhere in that decline phase, less than 100%, and based on their age and height, there will be other criteria to see if they qualify for the study, and further details can be explained at the trial site to see what we're doing to qualify the boys. I should also mention that if boys are screened and they seem to be walking above the cutoff, they can come back later, within 6 months, to see if their functioning now puts them in the qualification window, and they could enter the study later, even if they don't qualify the first time they're screened. In terms of exclusion criteria, I said we want initiation of steroids within 6 months prior to the start, or a change in steroid treatment that's been stable for at least 3 months. They can't have, I'm sorry, these are exclusions, so we don't want boys who initiated in less than 3 months. They shouldn't have been in our prior studies or exposed to Ataluren. They can't have been exposed to other investigational drugs within 3 months of the start of this study. And again, if they expect a major surgical procedure, such as a procedure for scoliosis, we don't want that to interfere with their participation in the study. If they've had any recent lower limb injury, that would also make them excluded until they recover. And they shouldn't be exposed to other drug therapy, although that can be discussed with the investigator at the site if they are on other drugs. Just to be a little more specific about what trial participation would entail, of course they need to sign an informed consent and agree to the testing that's required in the study. They should have a screening visit to determine eligibility within 2 weeks of when treatment would start, and then they will agree to be randomly assigned to receive Ataluren or placebo that is to be taken 3 times a day. The dosage is determined by body weight, so there's no fixed dose. It's to be taken in the morning, midday, and afternoon, and it's supplied in the granules that we've used throughout our drug development period. It's easy to mix with water, milk, or even semi-solid food, and then the boys will be expected to visit the clinic every 8 weeks. You should know that, as we've done before, reasonable expenses related to the clinic visits will be reimbursed, and we have guidelines of reimbursable expenses that can be provided to anyone interested. And upon successful completion of the study, participants in any country where Ataluren is not commercially available at that time will have the opportunity to enter into the extension study and receive the drug for free. So, as I said, this is extremely important to PTC and to the development of Ataluren, and we really encourage anyone on the phone, or if you know anybody who you want to make aware who might not be aware of our trial, that they should speak directly to their physician or contact the study sites. And we have currently over 50 sites in 18 countries. We've gone back to all the countries that participated in our 007 Phase 2A study, and we've also added new countries such as Brazil, Chile, Czech Republic, Poland, South Korea, Switzerland, and Turkey. We've also added some new sites in the United States, in California, Illinois, Ohio, and Texas. The sites that are participating are listed at the website that's here, www.ptcbio.com, and can also be found on clinicaltrials.gov. And in the next slide, I'm going to give you some other information to directly contact us if you wish. As we said, there's about 20 sites currently planned in the United States. This is the further information. I'll leave this up for a moment. As I said, you can get detailed information on www.clinicaltrials.gov or sign up for updates on this trial or on an Ataluren in general at the ptcbio.com site. We also have frequently asked questions of it that you can access there. And importantly, you can also address questions directly to Diane Getz, who's with me today, who's our Senior Director of Patient and Professional Advocacy, and Diane can be reached at dgetz, D-G-O-E-T-Z, at ptcbio.com. So I'm finishing up. I just have a couple slides now. People are appropriately curious about where PTC stands and where Ataluren stands in the regulatory process. You may be aware that about 2 weeks ago, there was a formal notice by the European Medicines Agency, the EMA, and simultaneously PTC issued a press announcement stating that our filing with the Europeans for a conditional marketing authorization was not approved and not recommended for approval by the CHMP, what they call their Committee on Human Medicinal Products in the EU. This was not unexpected, and it was consistent with our prior expectations based on a process that ran a number of months as our application was under review and as we had an opportunity to answer questions that were raised by the reviewers and the regulators. I said on this slide that this process for conditional approval in Europe is similar to, but not identical to, the accelerated approval process that exists through the FDA in the United States. However, there's a few important takeaways to help you understand this process and where PTC stands with the Europeans. Importantly, during this review process that runs more than 6 months, there was what's called a scientific advisory group that was called by the Europeans, in which they invite experts in DMD to come meet with them, with the company, with PTC present, where the regulators can ask questions and in a quite interactive atmosphere learn more about the disease and get their opinions on the data that's presented by the company. And we thought that that was a very important opportunity for PTC and the DMD community to educate CHMP members on the natural history of DMD, to explain our data, and to explain our choice of clinical endpoints and what we think are now accepted to be the types of results that the regulators should be looking for to approve any new treatment in this disease. You should also know that patient advocates were invited by the CHMP at that meeting, and also what's called an oral exam, where we again had a final opportunity to review our data with the EMA, the European regulatory authorities. Finally, in the European system, there is a process for appeal that's called a re-examination, and PTC does intend to take advantage of this. We thought it was justified to file an application for conditional approval originally because we thought we met all the criteria for a drug and a medical need that the conditional approval regulations are in place for in Europe. We thought our data was worthy of a full application and review process, and we continue to believe that the current data merits a re-examination, and so we will be requesting that. And through that process, there will be another review of the data and a final determination by the second quarter of this year, that is at the end of the spring of this year. And there's still substantial risk that this will not be approved by the EMA, but we do intend to go through this process and see if there is the possibility that the drug could be made available more quickly for patients than going through the full approval process. Having said that, we've had very good interactions with both the FDA and the Europeans, saying that this new trial, the ACT-DMD trial, will be critical in the U.S. to file an application and to get the full approval in Europe. Even if we were able to get conditional approval, their expectation would be that this new study would be enrolled promptly and completed so that the new data could be brought back to them to confirm the results that they've seen in the first study. So I want to conclude just thanking all of the people who have, and organizations that have helped bring Ataluren to this point. We proudly list, many members of PPMD who have been very helpful, as well as MDA, and also our interactions with FDA and all the investigators, physical therapists, and site coordinators who we've listed here, and I'm sure we've left out some, and most importantly to the patients and their families who have contributed and volunteered to be in our studies and also just been supporters of PTC. So at that point, our presentation is complete, and we're very pleased to answer questions, and I think we're going to ask Sharon to help us sort through the questions that have come in while I was speaking.
Yeah, thank you, Bob. I appreciate it. I realized I forgot to introduce myself at the beginning of the presentation, so if anyone doesn't know me, I'm Sharon Hesterly. I'm PPMD's Vice President of Research, and we're going to move into the questions section now. So a number of questions have come in during the talk. There are several about eligibility criteria, so we'll start with those. Someone has asked if his son turned 7 in June of this year, would he still be able to participate in the clinical trial?
I'm going to let Alan Ria, who's with us and who's our coordinator for the whole study, address some of these questions about eligibility.
Great. So thanks, everyone. So in terms of that specific question, we are targeted to complete enrollment by mid-2014. Of course, for the community and the company as a whole and regulators, we want to do that as quickly as possible. So by mid-2014, that kind of puts us in a window. So I think right now it's difficult to say whether or not that'll be June or July, but we're certainly on track to complete enrollment around the mid of 2014. So we certainly advise you to contact your nearest or preferred study site to talk about that further.
I think, I just want to elaborate on Alan's answer. I think we would absolutely be interested in a boy targeted that way who has a birthday in June or July. Our internal projections are that enrollment will be completed in June, but we could be off by a couple of weeks, and we also might choose to over-enroll the study slightly. So I would certainly, if a boy was in that category and otherwise eligible but didn't have his birthday, I think I would very much want to see that boy, come to one of our investigational sites and be screened and be ready. And I think it's more likely than not that they would be able to go into the study.
Okay. I have another question that's not quite a question about eligibility, but let me see if I've phrased this correctly. If a boy is already in another Ataluren trial, no longer walking, or has been, I assume, in another Ataluren trial, are they still eligible to continue the drug? So this, I think, is about continued access more than the current trial.
One of the things we wanted to make sure wasn't misinterpreted when the initial announcement came out about the European decision about our conditional approval application was that we do absolutely want to keep all of our studies open, and all the boys who are in our extension studies will be continuing to get Ataluren as long as they wish to. And actually it's quite important for us because we're actually quite excited that in the extension studies we are able to get further information about boys even if they're no longer ambulatory, about how well they're tolerating the drug. And in some sites we continue to do evaluations of efficacy so that we will be able to get some information about how the boys do even if they're not ambulatory.
Bob, we just lost you.
Oh, I'm sorry. Well, the answer was yes, and I said that we are
Okay, I think we have lost Bob. There he is.
Am I still there?
You faded out for a minute, at least on my end.
Okay.
I can hear you now.
All right, so let me just repeat that again. The answer to the question is yes, all boys who are on our current extension studies are expected to be able to continue, and that we did publicly announce that when the information came out about the European initial decision, we wanted people to know that PTC was absolutely continuing all of our studies, and it's very important to us to continue gaining information about boys long-term, even if they're no longer ambulatory.
Okay, and someone else is asking how many boys are currently enrolled in the confirmatory trial, and, basically how close are we to the full enrollment? I know you predicted mid-2014, but can you tell us where we are now?
So this is Alan again. What we could say right now, we're certainly well on track to complete enrollment by 2014. So I think we're confident that we could hit that milestone. So things are going quite well. Of course, we'd like to finish sooner, for multiple reasons, but so far so good.
Okay, and so then a few questions about endpoints. So someone has asked why you chose the North Star assessment as a secondary endpoint, given that recent studies have shown this is more relevant in boys aged less than 7 years.
So it's a great question. So in terms of the North Star, it's a really interesting tool, as Bob described, and it really collects information about abilities of the child in ways that other measures, like the time function tests and 6-minute walk, do not. There's been a lot of great work by a number of our colleagues, particularly in Europe, Eugenio Mercuri and Elena Mazzone. And I believe Elena Mazzone's 24-month data actually indicated patients that were above 7 years actually have a pretty linear decline of about 3 to 4 points in the North Star year to year. So I think that it's that linear decline. It's fairly sensitive to disease progression once you're above that certain age, as a whole. That's general population, and as well as the test is nicely correlated with the 6-minute walk test, which we know is sensitive to disease progression over a 1-year period.
For those who don't know, PPMD organized a really excellent meeting with the FDA last December where there was a very open discussion of drug development issues for the FDA, for all developers of new therapies, obviously beyond just nonsense mutation, for any type of mutation.
Danielle, are you on? Can you hear me?
Yes, I can hear you.
Can you hear me?
Hello?
Yes, I can hear you all.
So
okay.
I was just saying, the question is a very good question because everyone who's doing research in this area is trying to come up with the ideal endpoints for a study, and there was an excellent meeting with FDA, with considerable FDA participation in December that PPMD organized, and we're trying to stay current with sort of global standards. We wanted this new study, ACT-DMD, to be something that we could do consistently across the world. There's a lot of interest in the North Star in Europe, but we can also tease apart the different components if we wish, but we thought instead of having separated time function tests, the North Star was a good way to capture it all. And we'll see from this study, if it is more sensitive in different age boys. But we chose it as one of our secondary endpoints to try it out.
Okay, and then I'd actually like to follow on with a question of my own about the study design, and that has to do with steroids. I know you're requiring the boys be on steroids and on a stable dose, but are you also going to randomize looking for prednisone versus deflazacort and the time that the boys started steroids? Given that there's new data now that show that both of those things can have an impact on when the boys first start or how long they walk.
Sure, that's a great question, and there's been a body of evidence on steroids for the number of years, going back to the work of Birch Riggs in the late 80s. But certainly we had acknowledged the potential effect of steroids early on in terms of when boys initiate steroids, there could be a bit of a bump in their coming months, and that's published in the literature. So we've actually spoken with the experts, and as a stratification factor, actually stratifying patients that have been on steroids. All of them have to be at least on 6 months of steroids. So patients between 6 and 12 months of steroids, and patients outside of that, so 12 months or above, are each in separate strata levels. So that's one way, requiring all patients to be on steroids, but actually stratifying them by their duration of steroids. But certainly there's a number of different steroid regimens which we do permit, but I think as part of our statistical analysis plan, we'll be looking at subgroups of different types of corticosteroid regimens and deflazacort, and asking questions about deflazacort versus prednisone, et cetera. So that'll be certainly part of our ultimate analyses.
Okay, so a few more questions about the study. Someone is asking where people might find the information about reimbursement and what's covered.
The easiest answer is to contact Diane Getz through that website. Through her email that we gave on the site. If you want to put that slide back up while we're talking, Sharon, that might be useful so people can see Diane's email address. But that would be probably the most direct way to get a direct answer about what is expected to be covered in the reimbursement when necessary. Okay,
great. I've got this slide up. Okay, so one other question. Someone is asking if, based on the studies that have already been completed, can Ataluren be sold in non-U.S. or European markets, so elsewhere in the world?
No. So there is no country in the world where Ataluren is an improved drug. There are people, there are basic researchers who usually contact us, but they can get chemical sources of the drug. We don't recommend that. But in terms of a medical therapy, it is not available anywhere in the world right now.
Okay. And so then someone is asking, do you have any data on efficacy versus mutation type and location?
So that's an interesting question. I mean, we have small numbers, from the 007 trial. It was the largest study ever conducted at the time, and it gave us a large experience. But for individual mutations, we have, small numbers for each mutation. And frankly, we have not seen any marked difference in either the Ataluren effect or I think Dr. Craig McDonald might have just published a paper talking about, as a natural history, whether there's slight differences in certain mutations, but we have not seen anything, jump out from looking at our data by mutation. Alan is going to say a little more.
Oh, no, just acknowledging the dystrophin gene with having 79 exons, and I think we were pretty well represented across the 79 exons, but we looked at that closely in terms of correlations with change in 6-minute walk distance using placebo as a natural history. We really couldn't find anything, and I know that's a key topic for other therapeutic approaches like exon skipping, where we really need to find out if there's any difference in natural history from a region of exons versus another region of exons. But from our data set, we couldn't see anything.
Okay. Someone else is asking, how are the boys doing who have been on Ataluren since phase 1, or phase 2 in this case, a 2A study? I guess if you have a cohort who's had access to drugs for the longest amount of time, do you have some idea?
I must say we're excited that we are starting to gain that long-term data. As you may know, I assume most of the participants in this phone call are in the United States, but perhaps some are from other parts of the world. In Europe, we were able to amend our long-term study to capture in a little more detail ongoing 6-minute walk distance and even lung pulmonary function tests over time. So we're looking forward to being able to gather all of that data. Right now, we have just, a couple dozen patients who have been treated for more than a year on the new study extension, even though some of them had long periods before they got back on in terms of formally being placed back on it. And we have, a larger number who are about 6 months into it. So we're hoping that, maybe by the end of this year we might be able to look a little more at larger numbers. We obviously get a lot of anecdotal reports from parents that are very encouraging, but I wouldn't say we've been able to analyze the data yet. The good news, we know from safety that there's been very good tolerance and there's no late appearing side effects that we've seen, so that's good. The safety picture looks good long term, but that's where we are able to assess the long-term outcome. And again, as I said, we do allow boys, even if they've lost ambulation, to stay on the study. So even though it's an open label experience that's not a randomized trial, we may be able to say something about being able to help other parts of the disease even after ambulation's been lost.
Okay, so here's a perfect follow-on question, and it's someone whose son has been in Ataluren studies for a long time. Says, our son has been involved in the Ataluren studies for about 7 years. He stopped walking in 2011. His drug study visits now consist only of blood work. What are the markers being evaluated now that boys are no longer completing 6-minute time walk and other questionnaires?
Yeah, so I think if not knowing the patient particularly, but if he's enrolled in our open label study in the U.S., we are just collecting safety information. So with that trial, we've enrolled about 107 boys, and we've actually completed, the first boys that entered that trial have completed over 3 years of continuous exposure back in November, so we're getting a lot of great safety information. But unfortunately, we're not collecting, formal, data in the U.S. study, as Bob explained, but we look forward to gathering further information. Again, it's open label, so there's a lot of challenges with analyzing that data, but, looking at that type of data on an open label basis in our European rest of world open label extension study.
Okay, we have another question about cognitive abilities. Are you testing and analyzing cognitive ability variations? And I'm not sure what the asker meant exactly by variations, but are you testing anything related to cognitive ability?
Yeah, so I think at current, we've used somewhat of a cognitive-related tools in terms of we looked at working verbal memory in the phase 2B trial years ago, but really we saw a lot of stability there. There wasn't really any change. So in terms of an endpoint, I think that's really a challenge. But we have been getting, of course, anecdotal reports about different aspects of cognitive improvement as it relates to school functioning, et cetera. And I think to that end, as Bob mentioned, that's what really, one of the aspects that really prompted us to build this Activities of Daily Living survey and disease status survey, where we have different categories of ability, not just physical ability, of course, but emotional, energy, school, and cognitive function, that we're really trying to get those specific individual reports from patients and caregivers about any changes. So that's currently how we're looking to get that data.
Okay, that's great. When PPMD did an informal survey after the 2B closed, we got a lot of interesting feedback about exactly that sort of thing, cognitive and emotional changes. Someone else is asking, what is the upper limit on 6-minute time walk for the eligibility criteria? I think you mentioned that there would be one.
Yeah, it is. I think it was presented on the slide, but it's 80%, and I think it's percent predicted, which, as Bob mentioned, it factors in the child's age and height. So
it won't be a set
exactly.
distance. It's going to be according to this formula.
And again, I'll just reiterate: if a boy just misses on their screening visit, the investigator can ask them to come back again in a few months, and if they've changed and then are eligible, they can come into the study later, even if they might have just missed that cutoff in the first screening.
Okay. The boys who are under 7 and not eligible to participate, is there any plan to provide drug on a compassionate use basis for that group?
Currently, there is not. We don't have any traditional compassionate use program at this time until we complete these critical studies for the regulatory agencies.
Okay. Someone is asking, what are the participation requirements for the open label extension study?
Yeah, I think, the open label extension study, the key aspect, they've had to have received Ataluren in a prior PTC study.
Right, so you had to have participated. The open label extension is just going to be for people who were in the previous study, so it won't be something that anyone can join.
Yeah, that was really our fulfillment, to put the boys back onto Ataluren. Not just in the U.S., which we did the U.S. first, but that we then went out to the rest of the world to our prior patients and gave them the option to go back onto Ataluren, which many of them are already, but it's really for our prior patients.
Okay, so someone is asking about the timeline for when results will be published, and estimating that they probably won't be available until 2016, and is this correct?
So, the timeline Alan said is that we hope to have enrollment of 220 patients completed by the middle of this year, and then the last patient in would have their final 48 weeks of data in the middle of 2015. We will then, scramble to clean that data and assemble it and present it to regulatory authorities. And, once that is all collected, we would try to promptly submit it for publication in scientific journals. We also would most likely be presenting it at scientific meetings as soon as it was available and the data was completed.
Okay, so likely in 2016. I think this person did a very nice estimate and came up with the same timeline. And I think that is what it is. That's how long it will take based on enrollment and the fact that you have to wait for the last patient to finish the 48 weeks. Okay, so a question about opening the site. Is there any way to accelerate opening sites? And the question is, it seems like it's taking longer than originally planned.
Yeah, I think one great milestone that we achieved, particularly with the U.S., all U.S. sites are now active, and it has been challenging. Some sites are much faster to get up and running than others. There's multiple scientific reviews, IRB, contract negotiations, which that could be very challenging depending on the institution. So, it is certainly a range of 1 to 2 months, all the way up to the outliers that take 6 to 9 months or more. But we're so happy in the U.S. to have activated all of our planned sites.
But I would say, if this question is coming from a parent with a potential child who might be eligible, I wouldn't hesitate to get in touch with the site and be screened. And what we really ideally like to have is for the sites to have patients lined up, and then as soon as they're open, they can start to plan with their clinic visits and their workload to start bringing boys in who have already been screened and we know to be eligible. In some other countries, not so much in the United States, we want to encourage them to get the genetic testing and help with that if it's necessary, if it's not routinely done, so that we know the boys are eligible with nonsense mutations.
Okay, and just as an aside, too, this is something that PPMD Superhighway Project is trying to address, and that is one of the key things is the startup time that it takes individual sites to come online, and there's some real bottlenecks that I think most of us know about with IRBs and site contracts that we'll be taking a look at.
I think that's great, Sharon. So we're all encouraged that, PPMD is getting behind that, and will make it hopefully easier in the future for any drug study to get underway.
Right, and as you mentioned, in collaboration with Charlie's Fund, we'll be working on this. So someone else is asking, does PTC have any other read-through candidates or potential catalysts to amplify the benefits of Ataluren in the study? Or not in this study, but as you go forward?
Well, I'm not sure if I understand exactly. As Alan said, one of the things that's been exciting is we interact, both through PPMD, through other groups, and through our own interactions with the scientists around the world who are looking for the best way to measure outcomes in this disease. So we are in discussions about, someone asked about cognitive function tests. We've been talking about other measures of upper limb function to assess drugs even when the boys are no longer ambulatory. So we don't have a new study ready to discuss yet, but we remain very interested in thinking about how could we assess what Ataluren is doing in other populations.
I think they were probably asking about follow-on candidates if you had other drugs, like second-generation drugs in development.
Well, we have an active research pipeline, but we have not yet, announced a specific drug that we would target as the next development for PTC in DMD. But we obviously consider, DMD a core area of our expertise as well as other neuromuscular diseases.
All right. So we have a question about, has Ataluren been shown to skip over nonsense mutations? And I think we know the answer is yes, there, and it's been well published. And have you shown that it causes an increased dystrophin production? And I think you showed slides from the phase 2A study, but in 2B you don't have that data, if I'm correct, and you're not actually taking muscle biopsies for the confirmatory study.
Yeah, so let me just elaborate on it. When we describe Ataluren's mechanism of action, we call it a read-through process. We don't want to be confused with the other drugs that are true exon skipping, and we always make it clear that we're not competing directly with those drugs. They have their own population of boys defined by their genetic defect, which is different than a nonsense stop mutation. And the way Ataluren works, sometimes we describe it as thinking of a gene that has a period in the middle of a sentence, and we want to remove that period and allow the RNA to be read fully so you get a full-length dystrophin that isn't stopped prematurely. I showed that one slide of our phase 2A study, and maybe my language was subtle, but in the phase 2A study, we did that by doing a full biopsy, removing a full muscle from the toe of the boys before and after the study. And we think that might have been one factor that allowed us in that study to show a pretty good capture of dystrophin production. I showed, if you remember that slide, I said 61% of the boys exposed to different doses were able to be shown to have increased dystrophin production by that immunofluorescence picture that we showed and by other measures. When we did the large phase 2B study with tremendous a complicated regimen that asked a lot of the boys to come in and have this procedure, to have a biopsy done, in some cases, needing anesthesia or just, problems that we were appreciative that the boys went through it. But when it was all done, we found a lot of variability, both from technical issues of obtaining the biopsies and the way they were oriented, the way the needle biopsy was done. We didn't get reliable data on dystrophin. And as you know, there have been a lot of discussions now with the scientific community and the regulators about whether dystrophin can be reliably measured, and in the language of the authorities, is it a true biomarker that's been validated? And our agreement with the FDA and the EMA is that the new Dmd trial can be done with a primary endpoint of 6-minute walk, and if it shows the effect of Ataluren, it will be a positive study based on the 6-minute walk. So we work very actively with the scientists. We'd all love to see a reliable way to get dystrophin measured, but right now we don't think it's there, and we thought it would make the study much easier. And since we have the agreement of the authorities, to be able to measure 6-minute walk, but we feel very confident that from the phase 2A study in DMD, and also from now over 20 different studies in other types of diseases where there's a nonsense mutation, that Ataluren has repeatedly and consistently been shown that it can read through nonsense mutations. So that's where we are on that issue.
Okay, thanks for clarifying that. We're right at the end of the hour here, and I know that some people may need to go if you had exactly an hour set aside. But there are two final questions I'd like to ask because I think they're pretty important. And then if there are other questions I don't get to, we'll try and get answers to you offline later. But if we have just a minute to stay on the line, one quick question. Someone's asking, what about, for example, a 12-year-old who can't walk and has never been on a steroid? Can he participate? And I think that gets at the question about what about the boys? We asked about the boys who were too young, but what about the guys who are not currently ambulatory or not on steroids? Will they have any option to participate or get drug?
So unfortunately, I think the answer to that specific question is that we will only be able to do this study in ambulatory boys, because clearly the primary endpoint is a change in your 6-minute walk distance. So for now, we don't have another study that's available for a boy with that situation.
Okay, and then a quick final question. If the phase 3 trial is successful, and through an interim analysis that it's successful, could it be stopped and the drug available to others before the trial is finished?
So at the present time, the study is not designed to have an interim analysis. We could spend more time explaining why that is, but basically based on the rate of enrollment, by the time we were able to do an interim analysis with boys being able to, a substantial number of the boys enrolled being able to complete 12 months or even 6 months, it would be very far along in the study. So after talking to statisticians, we currently do not have an interim analysis planned for that scenario. So
okay.
So I'd be happy to just conclude for those who were able to stay on the phone, Sharon. We really appreciate this time and appreciate all the help PPMD has given us all along. We believe from everything we've seen that Ataluren has the potential to really be important, and I think some people a few years ago were hopeful that all of these drugs would that were going into the clinic for the first time might really produce cures. I think we're now more realistic. We think that the types of slowing of disease that we're seeing in the post-hoc analysis of the phase 2B study and what we hope to achieve by showing, again, a slowing of the disease in the ACT-DMD study is very important. And I think both through PPMD and some of the work that you've supported and talking to parents over the last few years, I think everybody feels that anything we can do to slow the progression of the disease at any stage is important. And we're hoping that we'll be able to show that that's what Ataluren's able to do. So we again appreciate all the support of the community, and we look forward to working with you. And again, we encourage you and anybody on the phone who knows someone who might be eligible for this new study to get in contact with our sites.
All right. Thank you, Bob. It's great to see the study underway, and thank you for everyone who participated by phone. We hope to have a recording of the webinar available in a few days, and we'll have an announcement about if that's possible relatively soon. So thank you very much, and this concludes our webinar.